Today's documentary will begin with a biomedical description of tuberculosis. This will then be followed by exploring the social dimensions of the homeless community and how they impact the onset and severity of tuberculosis. Following this, the influence of the social dimensions of the community on the biomedical aspects will be explored. Evidence-based solutions for decreasing the disease burden will then follow.
Symptoms of an active pulmonary tuberculosis infection. These include a bad cough lasting 3 weeks or longer, chest pains, coughing up blood or sputum, fatigue or weakness, weight loss, and a loss in appetite. What is tuberculosis? Tuberculosis is caused by mycobacteria called Mycobacterium tuberculosis. There are many characteristics of Mycobacterium tuberculosis that separate it from other bacteria. Where is it found? In Alberta, Canada, there are 4.8 cases of tuberculosis per every 100,000 individuals. In Calgary, there are 6.84 cases of tuberculosis per every 100,000 individuals. How does it spread? A person with an active pulmonary tuberculosis infection coughs up essentially droplets containing active forms of the tuberculosis bacteria. When these are inhaled by another person, they can initiate an infection in the other person's lungs. Here in the lungs is the prime target of the tuberculosis bacteria. The tuberculosis travels down the respiratory tract and into the lungs. The tuberculosis virus eventually reaches its targets of the alveoli in the lung. Most of the bacterium entering the alveoli are phagocytosed by alveolar macrophages. The few tuberculosis bacterium that survive being phagocytosed start replicating in the macrophage and diffuse to nearby cells. After a while, the adaptive immune response kicks in and assumes the structure of a granuloma. This essentially houses the tuberculosis bacterium and preventing them from spreading further. These blue cells drawn here represent the lymphocytes in the granuloma. This black line represents the fibrotic components, which is then calcified to hold the granuloma together. This initial lesion is called the Gond complex. Here a person has a Gond complex in the lung, plus a secondary dormant bacteria cluster near the kidney. In an individual with a healthy immune system, but a tuberculosis infection, the dormant tuberculosis cluster is going to produce these scouts. However, these will be quickly uptaken by macrophages and other lymphocytes. In an individual with a non-healthy immune system, such as one infected by HIV or exposed to a tumor necrotic factor, these scouts are not going to be uptaken by macrophages and the adaptive immune system. As a result, the dormant bacteria replicate the active bacteria uncontrollably, and this leads to the symptoms shown in an active tuberculosis infection.
So the social profile of the homeless in Calgary is really quite diverse. So what does it mean to be homeless? A common definition of homeless is someone who is unable to access safe housing on a daily basis, one that they can always go to and be comfortable going to. And so that's how we define our population of homeless individuals. And these homeless individuals have a very interesting demographic profile. There are approximately 3% of Calgarians are homeless. And of those 3%, the ethnicities and the age distributions are a bit different than seen in the remainder of the Calgarian population. Specifically, 79% of the homeless individuals are of the ages of 24 to 65. And another identifying fact is you can do it based off of where they were born, with approximately 25% of homeless individuals being foreign-born, being not born in Alberta and immigrating into Alberta. Another identifying feature would be based off of ethnicity, with approximately 61% of individuals being Caucasian, 18% being under the category of other, and then really interestingly, 21% of those individuals being Aboriginal or of Aboriginal descent. So what does all this mean? Well, it's important to recognize that the homeless community has very interesting and different issues with prevalence and disease control than does the housed population. So understanding the demographics of the homeless population is really important to understanding the prevalence of the disease. Many of the individuals that are homeless have significantly lower socioeconomic status. Almost all of them do, in fact. And what correlates with this is a much higher likelihood that someone will report having suboptimal health or not good health. They'll have low quality health. And there's been a lot of compelling research linking people that report lower just general standard of health to increased risk of contracting tuberculosis. Moreover, a recent study has found that homeless individuals that are living with poor health, or just homeless individuals in general, have a 20-fold increase in the likelihood of contracting tuberculosis as compared to the regular population. Moreover, our population in Calgary has a much higher rate of tuberculosis than does the general population. Absolutely, the social dimensions of homelessness impact dramatically the severity of tuberculosis. So many examples of it is these patients are much more likely to be immunocompromised, either through infection with HIV/AIDS or through other co-occurrent infections with hepatitis or sexually transmitted diseases, or just generally through being comorbid with other diseases. And this makes it much easier for the disease to progress with increased severity. Rather than being infected with the latent form of tuberculosis, one is much more likely to be infected with the more active and highly pathogenic, will have a higher pathology associated with it. So in that sense, absolutely there's a much higher severity of disease burden in this population than opposed to someone who would be immunocompetent, and generally people that are housed and are home full are actually less likely to be immunocompromised. So there's many things about this social community that exacerbate tuberculosis. First of all, this community has many barriers to accessing healthcare. Oftentimes it's inconvenient or far away, and so it's not very accessible for this community, which means that if someone thinks they might have tuberculosis, they might want to get help, they might want to get tested, but there is no way for them to do that. Another thing that can exacerbate this is a lack of health literacy. This community generally is undereducated, or has comparatively received less education and ability to understand and be literate than does the remaining population that is not homeless. On average, they've received significantly less education. And moreover, because of this, they may not even understand that they might have tuberculosis. And so it's our responsibility to ensure that they have access to health information. And so they might just think it's a cough, they may not know that it's really a severe disease, and they won't get access to healthcare. Even if they have access to healthcare, they won't try and use it or utilize it. Finally, due to the fact that much of this population is of foreign birth, their cultural values and the way that they understand health might be drastically different than the way we do. And in fact, in some countries such as South Africa, there's a significant taboo with having tuberculosis. And as such, they might even understand that they have tuberculosis, but they're really afraid to go and seek treatment. So it's really important to understand some of these cultural aspects that might drastically impact the prevalence and severity of this disease.
In the homeless populations, biomedical aspects of tuberculosis are most influenced through diseases that can compromise an individual's immune system. Diseases such as HIV and AIDS significantly increase the likelihood of homeless individuals developing tuberculosis. HIV/AIDS destroys CD plus T cells, which are imperative in activating macrophages that destroy the pathogen. These two diseases, for that reason, are most often found together in the homeless population. Smoking is also very common amongst the homeless population. Smoking destroys some very important defense mechanisms within the lungs. It damages the cilia of the lungs, and which makes it difficult for the lungs to clear out any pathogens that it may encounter. It has also been shown that smoking contributes to the development of tuberculosis directly. Examples such as these, HIV and AIDS and smoking, demonstrate that by being homeless, you are, via a number of social determinants, more likely to develop tuberculosis.
The homeless community are at a high risk for contracting infectious diseases such as tuberculosis, and the contributing factors could be due to malnutrition or the overcrowded conditions, which is highly problematic in homeless shelters because individuals are sharing the same breathing space, and that can facilitate the transmission of tuberculosis. Many interventions have been proposed in the past to try to decrease the burden of tuberculosis disease within the homeless community. What's important to note is that tuberculosis is preventable and curable. And that's quite alarming because there clearly are solutions out there, but there still is a high prevalence of the disease within the homeless community. Transmission can be prevented by prompt identification and treatment of the infected person. But what is challenging, especially in the homeless community, is the adherence to treatment completion, which is crucial for the prevention of relapse. There are treatments out there preventive treatments such as the tuberculin skin test screening to see if you have tuberculosis in the first place, or if you already have the latent form of tuberculosis, there is the isoniazid preventive therapy that is very effective of preventing the latent form of tuberculosis from progressing into the more active disease state of tuberculosis. But what's found in these communities is that there are poor adherence to the follow-up and the lack of sticking to the treatment regimens. It may be due to the lack of incentives, the lack of access to treatments, or just poor communication between the healthcare provider and the homeless patients. Most effective intervention that has been implemented in the past and is currently being implemented because it works is to use cash and non-cash incentives to try to get the homeless individuals to accept treatments and to come into the TB clinics for their follow-ups. Numerous studies have been conducted in Canada and the United States that have implemented this intervention, and collectively it has been proven to be an evidence-based solution for decreasing the burden of tuberculosis disease. So what that means is that upon completion of TB treatment, the individual will either receive cash, which is usually $5, or non-cash incentives such as vouchers or gift cards. It should be noted that non-cash incentives such as food vouchers are often used because of concerns of using cash as an incentive. Some healthcare providers believe that it's inappropriate to give cash to individuals with known alcohol or drug addictions.
Hello. Yeah, that's enough for today.